This is my rehabilitation plan for a tennis player with grade 1 right gastrocnemius strain. The gastrocnemius is made of two heads, medial and lateral. The medial head can be found at posterior surface of the medial femoral condyle, and the lateral head is found at the posterior lateral aspect of the lateral condyle of the femur. The gastrocnemius inserts at the posterior surface of the calcaneus via the calcaneal tendon, also known as the Achilles tendon, which is responsible for superficial posterior leg muscles to plantarflex the foot and stabilize the ankle joint. The soleus muscle sits just behind the gastrocnemius and acts as a support for the muscle during the plantar flexion. The tibia and fibula are two long bones in the lower leg that insert at the knee and the ankle. The tibia is weight bearing, which means it supports your body when you stand and move, whereas the fibula isn't as much as weight bearing, however, it provides structure to the leg. The talus can be found in the ankle joint, and it is the insertion point of the tibia and fibula, and its function is to support your weight and help your ankle move smoothly. The navicular bone is one of the 7 bones which make up the tarsus of the ankle and foot. It is located in the medial aspect of the foot and next to the cubital bone. The calcaneus is located inferior to the talus and posterior to the midfoot and is responsible to act as a lever for the leg and toe muscles. The medial collateral ligament, also known as MCL, is wide and flat, found on the medial side of the knee. Proximally, it attaches to the medial epicondyle of the femur. Distally, it attaches to the medial condyle of the tibia. Its main function is to prevent the leg from extending too far inwards, but it also helps to keep the knee stable and allows it to rotate. The lateral collateral ligament, also known as LCL, is located on the outer side of your knee and runs from the top part of the fibula to the outside part of the femur. The function of this ligament is to prevent excess varus stress and posterior lateral rotation of the knee. Gastrocnemius strain is a common calf injury, also called a tennis leg, that typically occurs in physical activity that requires change of direction at great speed. As we can imagine, during a tennis rally, the player has to change directions as soon as possible in order to get to the other side of the court and return the shot played by the opponents. Most of the time when this happens, we see the player slide on the court, and during this movement, the gastrocnemius is overstretched due to the sudden change in movement, resulting in partial or possibly total rupture or tear of the muscle. When this occurs, the patient will feel sharp pain in the muscle. There will be visible swelling and bruising along with tenderness across the muscle. Our client is experiencing grade 1 strain, which is associated with micro tears in the muscle fibers that cause mild pain or soreness but minimal reduction in strength and range of motion. Grade 1 is usually where less than 10% of the muscle fibers are disrupted, whereas within grade 2, the muscle fibers experience between 10 to 50% of disruption, causing a bigger reduction in strength and range of motion. Finally, within grade 3, it signifies complete rupture, which presents severe pain, disability, and loss of muscle function. At this grade, more than 50% of the muscle fibers are disrupted. Quick overview of the rehabilitation plan for our client during the first 3 days from injury. I'll ask the client to follow the Love and Peace protocol, but mainly protection, compression, and elevation. I'll also perform some passive movements on the client in order to examine the injury, which will allow me then to move on to my intermediate stage that will include isometric, concentric, and eccentric contractions, balanced exercises, partial and full weight bearing exercises, weighted exercises, core stability and mobility exercises, and also cardiovascular exercises. First step in the early stage is protection. As Dr. Ruben van Dusen states, offloading of the injured or at-risk foot area can help avoid postural instability and risk of falling. First way is to fully offload the limb. This is usually done within the day of the injury and the first day after the injury. Second video shows me still using the crutches, however, I'm starting to apply some sort of weight on the injured limb. However, this is still less than 50% of my weight. Depending on the pain, after the first day, the patient can move on to this technique or stay at the first one in case of any major pains. In the third video, we can see me compressing the gastrocnemius area. Compressing the injury helps reduce and prevent swelling. Swelling also causes more pain to the injury since it puts a lot of pressure on the injured area. Since compressing can reduce swelling, therefore it will help reduce the pain as well. During the elevation phase, we ask the patient to elevate the limb above the heart level. By doing so, it will help minimize the swelling by allowing the fluid to drain away from the area. I recommend doing this as often as possible during the day to minimize the pain. With the passive movement, I will perform all the movements at the ankle joint, starting with dorsal and plantar flexion and ending in eversion and inversion. Passive movement will always be done within pain-free range, consulting the client if they are comfortable within that range to avoid any further micro tears. within that muscle. Now moving on to the intermediate stage of our rehabilitation, we'll start by performing muscle contractions. According to Robert C. Mask's research, a 3 to 10 second duration for 1 to 5 reps helps to rebuild the strength back within that muscle. For the presentation purposes in these videos, I'm only performing contractions for inversion. In the first video, I'm performing the isometric contraction. In this contraction, I ask my client to invert his ankle into my hand and match my strength to increase the tension in the muscle while keeping its length constant. The strength of the contraction I would ask my client to go at would be around 20 to 30% in order to avoid any further damage to the muscle. My second video shows a concentric contraction where I ask my client to once again resist my hand at 20 to 30% of their strength. However, in this contraction, I'll allow the foot to invert slowly. This way, the muscle tension rises to meet the resistance, then remains stable as the muscle shortens. The third video shows an eccentric contraction performed on our client. In this contraction, we'll start with the muscle concentrically contracted, and I once again ask him to match my strength. And however, in this instance, I'll ask the client to allow me to push the ankle back into its natural position. This way, the muscle lengthens as the resistance becomes greater than the force the muscle is producing. This part of rehabilitation is focused on mobility exercises as it helps our client to regain flexibility and overall strength for the muscle. In the first picture, we can see me performing a wall stretch. For this stretch to be performed correctly, I would ask my client to stand close to the wall and place the palms on the wall. Then I would ask them to bring their injured leg around the foot back and then bend the other leg. Whilst leaning against the wall, I'd ask them to try and place the heel of the injured leg down on the ground flat whilst keeping the same leg straight. This stretch should be held from 20 to 30 seconds as it takes 20 seconds for the muscle to relax and elongate. Second picture shows me once again stretching my gastrocnemius using the elevated foot stretch. In this stretch, I would ask my clients to stand close to the wall and place their elbows against it. The next step would be to place the toes of the injured leg also against the wall whilst keeping the heel down and the leg straight. The duration of the stretch would be the same between 20 to 30 seconds for 2 to 4 sets depending on the client's comfort. In these two videos, we can see our client using self-myofascial release techniques using the foam roller. Foam rolling can help relieve muscle tightness, soreness, and inflammation and increase your joint range of motion. According to Corte G 2015, it is recommended that myofascial release occurs from 60 to 90 seconds, but even up to 5 minutes with 3 repetitions and a break in between. For the correct technique to be performed, I'd ask my client to place the injured leg on a foam roller and place the roller just under the gastrocnemius. In order to get them rolling, I'd ask them to elevate the glutes off the ground and support the body weight with their arms, and then using the arms and core strength, create a back and forth rocking motions, allowing the limb to roll on the foam roller. We'll also release some tension from the hamstring using this technique due to the assumption that the injury occurred due to the muscle above and around it being tight and underactive. One of the most crucial aspects of your tennis game is your ability to maintain good balance while striking a forehand or backhand tennis stroke. This will allow you to play with consistency and power during a game. My first stability drill, shown in the video, is a simple throw and catch whilst my client stands on one leg. This drill is very useful for a tennis player as not only does it work the stability, but it involves hand and eye coordination. This drill can be regressed into a single leg stance without the ball and slightly progressed to single leg stance with eyes closed. The second video shows me performing a squat using stability pads. This drill will mainly focus on the ankle stability and quadricep strength. However, if this drill is too hard to perform, we could use a single pad and just stand on it with one leg for as long as we can to rebuild more stability in the ankle. In tennis, there is a lot of core involved and mainly the external obliques that allow us to rotate our trunk. As the tennis player is about to hit the ball, they will reach out and rotate the trunk in order to generate more power in their stroke. First exercise for the core, but mainly for the external obliques, is the Russian twist. In this video, we can see me performing it with weight in my hand and with legs elevated. However, if this is too advanced for my client, I'd ask them to drop the feet down and then perform the exercise. The last core exercise is for overall abdominal area to keep them in shape and to maintain abdominal strength. In this exercise, I'd ask my client to perform an abdominal crunch, meaning they have the knees bent at 90 degrees and planted with the hands on the head I will then ask them to bring their chest to the knees or as far as they can. If they find it too difficult, I'd ask them to just elevate the chest off the ground. However, if it's too easy for them, I'd progress it into V crunches, meaning they elevate their legs and perform the same movement. Both exercises will be performed at 12 to 15 rep range for 3 sets in order to build muscular endurance. Banded exercises are an ideal tool to help use in rehabilitation as they help our client to focus on work on the injured muscle, which can speed up the process of rehabilitating them. In this video, we can see me asking my client to perform a dorsiflexion as I create tension at the resistance band. We can regress this into a lighter band, or we can progress this into a heavier band. The reason we perform partial weight bearing exercises is to avoid putting all the stress on the muscle straight away, which could lead to an injury occurrence. The first partial weight bearing exercise shown in the video is supported calf raises. We'll ask my client to lean against the bed and apply most of his body weight on it as they go into the tiptoes to activate the gastrocnemius muscle. If this is too hard for my client, I'd regress this to a seated calf raise, where I would have them fully seated on the chair and just elevate the heels off the floor. Whereas if this exercise is too easy, I'd ask them to perform it with one leg elevated. Second weight bearing exercise will be back supported squats, where my client will have a yoga ball placed between the back and the wall, and they will use the ball as support. This exercise is good to test the ankle and hip mobility, as they don't have to worry about standing up straight and keep the perfect technique. As shown in the next two videos, to make it full weight bearing exercises, we remove the yoga ball and the bed to increase the muscle activation and get our client back into full movement to bring that muscle memory back into action, which will prepare our client to move on to weighted exercises. All these exercises will be performed within the 12 to 15 rep range for 2 to 4 sets to rebuild muscular endurance. The last part of the intermediate stage is the weighted exercises and cardiovascular exercises. This means our client is ready to get back into the gym and start applying weights into our workouts. We can also work with our clients in different rep ranges, for example 1 to 5 to build strength, or 12 to 15 to build endurance depending on the muscle group. In the first video, we see our client performing a bicep curl. Although this is a gastrocnemius strain, we can't disregard the upper body muscle, therefore keeping them in shape is very important. I ask my client to keep their elbows tight to their body and keep them in place as they flex and extend at the elbow, activating the bicep. Our bicep is responsible for a flexion at the elbow, and during a tennis serve, the player will have to flex their arm back in order to generate power in their shot. The second video shows our client performing lateral raises for the lateral head of the shoulder. Our client was instructed to raise the dumbbells up and to the side with the pinkies pointing up. To activate the shoulder, this exercise will help our client to control the racket when it's needs to slow down or sped up depending on the game. Cardiovascular exercises such as swimming are good for our client that's recovering from a recent injury, as the water reduces impact and stress when exercises, supporting injured muscles and joint during recovery. Cycling, on the other hand, is good for our client as it involves all the lower body muscles, and it is researched that cycling is great for active recovery as it flushes blood and therefore oxygen around the body, promoting the healing process. I suggest my client to do these cardiovascular exercises around 30 to 60 minutes 3 times per week to maintain cardiovascular endurance.